These are my disclosures, research funding. So esophageal and gastric cancer, we'll see about 40,000 cases this year. We certainly see an ongoing decline in distal gastric cancers and an ongoing increase in adenocarcinomas of the esophagus, GE junction, cardia. And we have made survival improvements in the last 30 years, certainly gastric cancer, 16%, up to now 27% in the 2000s. Esophagus cancer, a 5% survival in the 70s with surgery alone, now up to about 20%. And I think these improvements in survival are due to usage of adjuvant therapy, as well as I think also improvement in postoperative care, particularly of esophageal cancer patients. So we have made modest progress, but clearly these are very highly virulent diseases and we need to do better. So what's becoming increasingly clear with esophageal adenocarcinomas and more distal gastric cancers is these are molecularly distinct entities. If we look at how RNA expression clusters in these different diseases, you'll see that there are really three separate patterns of expression. GE junction cancers, these are the Barrett's reflex-related cancers. Then the more distal gastric cancers, intestinal cancers that tend to be related to H. pylori infection. And then the more diffuse gastric cancers, they clearly are three distinct entities, even though they're all adenocarcinomas. And if we look at this as a Venn diagram, we can see that there is sharing of certain gene overexpression among the three subtypes, but then there are also unique genes that are affected in each subtype. So these are three different diseases and certainly have different natural histories, although the treatment to some extent does overlap. So how do we select out patients with esophagus, GE junction, gastric cancers for neoadjuvant treatment? We use endoscopic ultrasound. Certainly for esophagus and GE junction cancers, if you're T2 or higher, T2-3 node positive, you should be considered for neoadjuvant treatment. If you're T1A, very superficial T1 tumors, you can actually get away with endoscopic resection, endoscopic mucosal resection. If you're a more deeply penetrating T1 tumor into the submucosa, because of the risk of lymph node involvement, these are patients that we would send for surgery. But again, even for T2-3 node positive, we would consider a preoperative therapy approach. The prognosis is not good. So we have consensus now, I think, in the treatment of upper GI cancer, certainly esophagus and GE junction cancers. We all tend to agree now that this group of patients, T2-3 node positive, should get something more than surgery alone. Now we have two camps. We have the preoperative chemotherapy camp. These are the believers in the MAGIC trial, which is more of a gastric cancer trial. Preoperative chemotherapy with either ECF or CF in the French study, about a 14% improvement in overall survival with the perioperative chemotherapy alone. The problem is, however, that the larger studies that focused more purely on esophagus and GE junction cancers either failed or had marginal impact. And the largest study, MRC-OE02, this is the British trial of platinum 5-FU, 800 patients, only a 6% improvement in overall survival in long-term follow-up. Then we have the Kelson trial. This is the 450-patient American trial, perioperative platinum 5-FU, absolutely no benefit in outcome. And then a more recent European trial where they used endoscopic ultrasound, laparoscopic staging, and the EORTC also failed to show any improvement for chemotherapy alone in esophagus and GE junction cancer. So conflicting data on chemotherapy alone. And if we look at the meta-analysis of chemotherapy trials, we do get a significant difference, but the hazard ratio is only 0.83. So it's about a 17% improvement with chemo alone. Most of us don't start to get too happy until we see hazard ratios of 0.75 or better, indicating a 25% or greater improvement. So then, a little over a year ago, actually this is about a year ago, in the New England Journal of Medicine, the CROSS trial was published. This was a preoperative trial of esophagus and GE junction cancers using modern chemotherapy, no more 5-FU cisplatin, weekly carbotaxol and radiation followed by surgery versus surgery alone. This used kind of the lung cancer regimen that's given with radiation. And this was a well-conducted study. Everybody had endoscopic ultrasound. The vast majority were T3N1 adenocarcinomas. very feasible to deliver this treatment. 93% of the carbotaxol radiation was delivered with really acceptable toxicity. And all of the outcomes in this trial were improved with chemoradiation. You had an improvement in R0 resection rate from 69% to 92% with chemoradiation, so enhanced ability to operate, and survival was significantly improved on the carbotaxol radiation arm compared to surgery alone for esophagus and GE junction cancers. And they achieved a 13% improvement in 5-year survival. The median survival was nearly a 2-year improvement. And again, the hazard ratios were pretty respectable. For adenocarcinoma, 0.73, and almost a doubling for the squamous cancers. And pathologic complete responses were high. For squamous, nearly 50%, and for adenocarcinoma, 23%. So if we look now at the meta-analysis data, which actually includes the cross data for chemoradiation plus surgery versus surgery alone, now you get 0.75. So yes, you get benefits from both approaches, but I would argue that the chemoradiation approach, you get a better survival benefit, and I think this is one of the better conducted studies of a modern combined modality treatment. So what do we do? I think that perioperative chemotherapy does provide some benefit. I think that combined chemoradiation translates into better survival and more pathologic complete responses. So what's happening now in the U.S. in neoadjuvant treatment? We have an ongoing trial of neoadjuvant chemotherapy in esophagus and GE junction cancers. This is CLGB 80803. We actually combine the approaches of induction chemotherapy and chemoradiation and basically ask the question, early on in treatment, does PET scan response give us an idea of whether or not the patient's responding to treatment? So on this trial, PET scan is performed early on after induction treatment. Patients get treated with either Folfox or carbotaxol induction chemotherapy. A PET scan is performed 5 weeks into treatment. If the patients show that they're responding to their assigned treatment, they'll continue the same chemo during radiation. If they're PET non-responders, and patients that are PET non-responders during induction treatment tend to do poorly. They have poor survival, poor response, poor R0 resection rates. The non-responders will cross over to the other chemotherapy. So this is using PET scan response as a biomarker to direct therapy to try and improve the outcome in these underperforming PET non-responder patients. So what about gastric cancer adjuvant therapy? Our understanding of adjuvant therapy has also now evolved just beyond the McDonald approach. So, it's almost over 10 years ago now that Jack McDonald published results for gastric cancer showing that 5-FU in radiation adjuvant treatment improved outcome. But these were for patients that had suboptimal surgery. The vast majority of patients on the McDonald trial had even less than a D1 resection, and the biggest impact on radiation was affecting local recurrence. Then we have the MAGIC trial that showed that perioperative chemotherapy, even without radiation, improved survival, 13%, and many academic centers jumped on this for distal gastric cancers. And now we have data, a resurgence of interest in adjuvant chemotherapy alone, particularly after a D2 resection is done. 2 recent studies from Asia, 2,000 patients, D2 resection, no radiation. The Japanese S1 study, which is oral 5-FU, S1 for a year, also improved survival compared to surgery alone. And then more recently, the Koreans did capecitabine oxaliplatin, clearly a Western regimen for chemotherapy, capecitabine oxaliplatin for 6 months versus surgery alone. And this also showed a survival benefit. So now we've got options in the adjuvant treatment of gastric cancer. Certainly 5-FU radiation in a patient that maybe didn't have the best surgical sampling of lymph nodes. Perioperative chemotherapy if you're going to select your patients with endoscopic ultrasound. And if you've got a patient that had a good D2 resection, there is very compelling data that adjuvant chemotherapy with capecitabine and oxaliplatin, even without radiation, is acceptable. This is the classic study. This was published in Lancet last year. 1,000 patients, D2 resection randomized to observation versus 6 months of capecitabine oxaliplatin. And this showed significant disease-free survival improvement, 14%. And the hazard ratio was 0.69, actually 0.56. So this was a significant benefit for adjuvant chemotherapy after D2 resection. And I think after much trepidation and bloodletting on my time on the NCCN guideline panel, I got them to adopt this as an option for NCCN guideline treatment if a patient's had a D2 gastrectomy. Pretty much all subsets benefited from adjuvant treatment, all stages of disease, particularly node-positive patients. What about the role of radiation? I think this is an ongoing question. The trial that's probably addressing the post-op radiation question the best is the Critics trial in the Netherlands. Everybody gets perioperative chemotherapy with ECX, and then a randomization to get or not get radiation post-op. So this is going to ask the radiation question in a perioperative setting in a randomized trial. And actually, there are some data to suggest that even after D2 resection, adding radiation to chemotherapy may have benefit. The ARTIST trial that was published in the JCO in 2011 looked at about 600 patients after D2 resection and compared capecitabine cisplatin for 6 months with or without radiation. And when you added radiation, even after D2 resection, you got another 5% improvement in disease-free survival. So even in the Asian studies after D2 resection, there may be some added small benefit combining radiation with chemotherapy. So then just the last topic I want to cover for metastatic upper GI cancers is chemotherapy. These are the industry standard regimens, ECF and DCF, 3-drug regimens, docetaxel platinum 5-FU, epirubicin platinum 5-FU. None of these really hit home runs. I mean, you have response rates of about 35 to 40%. Time to progression about 6 months, and survival about 9 to 10 months. I would make the argument that for most of our patients, 2-drug regimens, these are also phase 3 regimens, achieve similar outcomes, including capecitabine, platinum, FOLFIRI, FOLFOX, very similar response rates, time to progression, and survival. I tend to reserve the 3-drug regimens for high-performance status patients that are willing to tolerate more toxicity. And actually, some data sets suggest that patients, older patients, there's a recent randomized trial looking at DCF in patients over the age of 60, showed DCF was no better than FOLFOX in older patients. So what about second-line chemotherapy? There are a number of recent studies that have validated the activity of second-line chemotherapy, improving survival in gastric cancer. This was a presentation at ASCO last year from Japan. Patients failed platinum 5-FU and then got randomized to get either weekly paclitaxel or irinotecan. And both of the arms achieved a survival of about 8 to 9 months, which is respectable in the second-line setting. And the outcome for paclitaxel and irinotecan was fairly similar. Response rates trended a little better in the taxane arm, 21 versus 14%, but indicated that either of these treatments could be considered an option in second-line treatment. Then some other recent studies. This is from the GI Symposium a few weeks ago. The Cougar trial, I think you had to be a 65-year-old lady chasing a young male oncologist to go on this study. But the Cougar trial randomized 168 patients with gastric and GE junction cancers to get best supportive care or single-agent docetaxel, and this was a positive trial for chemotherapy. Modest improvements in overall survival, responses in about 7% of patients. And then another trial, best supportive care, Kang, this came out in JCO in 2012. Best supportive care after, again, patients failed platinum 5-FU, and they could get either docetaxel, a little bit more kindler, gentler dose here, docetaxel versus, or irinotecan versus best supportive care. And this also showed, again, a benefit for active chemotherapy, modest survival improvements for chemotherapy versus best supportive care. And again, the taxanes seem to do a little better than irinotecan in terms of response. So second-line taxane, I think, is now considered a standard. And this just shows the chemotherapy arm versus best supportive care for overall survival. So then lastly, before I shift gears to pancreatic cancer, there are some interesting updates in molecular targeted agents in esophagogastric cancer. Randy talked about these usual suspects in colon cancer. These generally are not affected in esophagogastric cancer. So KRAS mutation, you just don't see it. BRAF mutation essentially is 0. EGF is overexpressed, but essentially all the drugs failed. I'll show you the negative laundry list in one slide. Virtually every EGF drug tested in esophagogastric cancer has failed. The winners here may be clearly HER2 overexpression in about 25%, and we do know from the TOGA trial that trastuzumab does improve outcome when combined with chemotherapy in HER2 positives. And I'll show you some interesting data for c-Met drugs. This is a viable target because c-Met is overexpressed in about 40% of gastric cancers. So the TOGA trial, you've seen these data many, many times. It took 4,000 patients to get 600 HER2 positive, randomized to get chemotherapy with or without trastuzumab, clearly showing a survival benefit for trastuzumab. If you were a high overexpressor, immuno 2 plus, FISH plus, or immuno 3 plus, you almost had a 5-month improvement in survival and a modest improvement in response rate. So trastuzumab we now use in practice first line in the HER2 positive patients. And progression-free survival also was improved. So there's some interesting data coming out now for alternative HER2 targeted agents. The LOGIC trial, which Randy Hecht is running globally, looks at capecitabine oxaliplatin with or without lapatinib in HER2 positive. So this is a first-line trial of lapatinib. The TITAN trial, this was presented at the GI Symposium a few weeks ago. Second-line therapy, HER2 positive, paclitaxel with or without lapatinib. Unfortunately, a woefully underpowered study, and they only saw progression-free and survival benefit improvements in the subset of very high expressors. So if you were immuno 3 plus, lapatinib added to second-line paclitaxel improved survival by almost 7 months. But again, this was a small subset of an underpowered trial. So there may be some evidence that lapatinib may have some efficacy second line in HER2 positive. Drugs in development include Pertuzumab. This is the drug recently approved for breast cancer combined with trastuzumab. This is going to be looked at first line in combination treatment in gastric cancer, and in second line it'll be a comparison of paclitaxel and TDM1. There are other drugs being studied, include afatinib, which is the HER1, HER2 tyrosine kinase inhibitor. And we have an ongoing national trial of trastuzumab, just to advertise this, RTOG 1010. HER2 positive esophagus and G junction cancers get assigned to carbotaxel radiation followed by surgery with or without the addition of trastuzumab, as well as trastuzumab adjuvant treatment for an additional year. So what about the negative trials? This is the everolimus versus best supportive care was negative for overall survival. We await the results of a second-line trial in looking at paclitaxel with or without everolimus, and then this litany of EGF negative studies. One of the choices, the choice that pretty much everybody got correct, the REAL-3 trial was staggeringly negative. ECX with or without panitumumab. Panitumumab was deleterious to patients on this study. Chemotherapy alone was better. Another deleterious trial from the UK combining cetuximab with radiation in esophageal cancer also resulted in inferior outcome compared to patients that got chemoradiation alone. And then another negative trial, gefitinib versus best supportive care, second line, also failed. The REAL-3 trial, I'll just walk you through, because remember, you got to do before you start giving patients drugs that you think are going to work, you got to validate them in phase 3 trials. Sometimes you get an unpleasant surprise, as we did in this study, which randomized patients to EOC versus EOC plus panitumumab. And basically, if you were unfortunate enough to get randomized to get panitumumab, you had significantly inferior overall survival, significantly inferior progression-free survival. So this was a case in point where you think you're helping the patient and you actually were hurting the patient. I think pretty much all the available EGFR receptor drugs are pretty much off the table now in esophagogastric cancer. So I just want to talk briefly about c-Met. A lot of interest in this pathway now in hepatocellular cancer and now esophagogastric cancer. This is c-Met is a receptor-mediated tyrosine kinase. The ligand is hepatocyte growth factor. There is downstream signaling through PI3 kinase and AKT, and also crosstalk between the integrins and ecadherin. So recently, a randomized phase 2 trial combined Rilotumumab with chemotherapy in esophagogastric cancer. They looked at 2 different dose levels of Rilotumumab plus ECX chemotherapy. And again, 40% of patients had high expression of c-Met by immuno, so this is a significant subset of patients. And if you were c-Met high and got Rilotumumab, you had significantly better progression-free and overall survival. There did not seem to be a benefit in the c-Met negative patients. So here's a biomarker that may select out a patient group for further study. And now the Rilomet study is going to open globally, looking at ECX chemotherapy with or without Rilotumumab in the c-Met overexpressing patients. There now may be a resurgence of interest in VEGF in upper GI cancers. As you know, the Avogast trial, this is the bevacizumab trial in metastatic disease, failed to improve survival even though there were trends. So adding bevacizumab to first-line chemotherapy in gastric cancer did not improve outcome. Charlie Fuchs presented a few weeks ago data for ramucirumab. This is a humanized antibody blocking the VEGF receptor 2. This is the ImClone, the 1112 drug. Randy actually listed this on his VEGF schema slide. So this essentially blocks the binding of the ligand to the VEGFR2 receptor. 355 patients failed first-line chemotherapy and then got randomized to best supportive care versus ramucirumab every 3 weeks. And this was a positive trial for single-agent ramucirumab. It improved progression-free survival by 1.7 months, hazard ratio pretty significant, 0.48, and a modest improvement in overall survival of about 1.4 months, and disease control was improved. And essentially, this drug had no toxicity. So I think this is going to be on the radar for FDA approval sometime later this year, ramucirumab as a second-line treatment option. So then lastly, I know I was entrusted to cover a lot of ground in 25 minutes. We'll talk briefly about some of the recent data for pancreatic cancer. So if we summarize current standard care for metastatic disease, most of us consider FOLFIRINOX the new standard in good performance status patients. Gemcitabine combination treatment is the alternative in good performance status patients. And then in the adjuvant setting after surgery, we tend to give adjuvant gemcitabine for 6 months at a minimum. Whether or not radiation is added is debatable. For hepatocellular cancer, the only recent new findings, sorafenib for treatment of metastatic disease, and for cholangiocarcinoma, that gem platinum was better than gemcitabine alone in metastatic disease. So if we look at the evidence for gemcitabine adjuvant, this is the German trial looking at gemcitabine versus observation after surgery. And here you got a doubling of 5-year survival, 9 to 21%. So many of us feel that based on this study, adjuvant gemcitabine for 6 months became the standard. SPAC3 compared 5FU with gemcitabine, actually saw no difference after resection. So if patients have trouble tolerating gemcitabine or have allergy, it is defensible also to give patients 6 months of 5FU-based chemotherapy as adjuvant as well. Now, a few weeks ago, a very provocative study came out of Japan looking at adjuvant therapy after resection in Japanese patients, a randomized phase 3 trial of gemcitabine, standard gemcitabine versus S1. S1 is the oral 5FU in Japan. It's basically Tegafor combined with Uracil. And basically, patients had curative resection for pancreatic cancer and were randomized to get 6 months of gemcitabine versus 6 months of S1. S1 is not available in the U.S. And this actually showed a benefit for S1. S1 resulted in a significantly better 2-year overall survival, 70 compared to 53% with a hazard ratio of 0.56. I know many of my colleagues feel that there's some magic about S1 in Japanese. I think basically in Japan, Japanese patients tolerate much higher doses of S1. In Western countries, we tolerate much lower doses. So I don't think we can translate the findings in this study to the West, but certainly this is probably going to establish S1 as the standard adjuvant treatment in Japanese patients. And this is the ongoing, just an advertisement for the ongoing adjuvant trial in the U.S. Gemcitabine with or without radiation. Patients get gemcitabine, and then at the end of their treatment get randomized to get or not get radiation. And up front, there's a randomization to get or not get erlotinib. This trial is actually accruing pretty well, and the Europeans recently joined. We all know about FOLFIRINOX and gemcitabine in good performance status patients. Substantial survival improvements for FOLFIRINOX compared to gemcitabine alone, and substantial response improvements. So obviously good performance status patients, FOLFIRINOX is our preferred initial treatment. Now, very, very exciting, provocative data presented at the GI Symposium a few weeks ago, because up until now, except for erlotinib, every gemcitabine combination phase 3 trial failed to improve outcome until the MPACT trial, which was a study of gemcitabine versus nab-paclitaxel. This is Abraxane, the albumin-bound Taxol, albumin-bound paclitaxel plus gemcitabine versus gemcitabine alone. Modest improvement in progression-free survival from 3.7 to 5.5 months, and toxicities were higher rates of neuropathy and neutropenia, but clearly an improvement compared to gemcitabine alone. So I think we'll now have an alternative to FOLFIRINOX. I will comment, however, that the Gem-Abraxane data was somewhat in between gemcitabine and FOLFIRINOX. The overall survival for Gem-Abraxane was about 8 months, whereas you still get that 11-month survival for FOLFIRINOX. So I think Abraxane did not match FOLFIRINOX, but it is an alternative with some modest improvements over Gem alone. I think still FOLFIRINOX should be the first choice in the good performance status patients. And then lastly, I just want to comment on another study, oral presentation from the GI Symposium, because many of us wonder whether we should use gemcitabine during radiation in patients that have unresectable disease, unresectable pancreatic cancer. And this was a randomized trial from Britain of 114 patients. Everybody got upfront gemcitabine and then 50/40 Centigray with either weekly gemcitabine or capecitabine. So looking at capecitabine versus gemcitabine as a radiosensitizer, it turned out that the gem arm had significantly more toxicity, 18 versus 0% heme tox, 26 versus 11% non-heme tox, and the survival actually trended better in the capecitabine arm. So many had trepidations about not giving gemcitabine during radiation, but I think these data argue that capecitabine is better tolerated and potentially results in better survival. And then lastly, the CMET data in HCC, just to mention the drugs. Tuvantinib is a tyrosine kinase inhibitor that targets CMET. This was a study performed in HCC. And basically, if you were a CMET high patient, you got an improvement in survival with the drug Tuvantinib. So there are plans to look at CMET overexpressing HCC and this drug. And then another one, Cabozantinib, this just recently got approved for prostate cancer. This was a placebo-controlled trial in patients with HCC. And they did see an interesting overall survival, potential prolongation. So this is another drug to keep on your radar for HCC. And I'll just plug the CLGB trial ongoing, which is the comparison of sorafenib alone with or without sorafenib doxorubicin. And I think with that, we'll pause for the questions, and thanks very much.